Okay. Okay. Hello,
You're on.
everybody. I'm Mark Cantro. I'm a palliative care doctor, and one of my colleagues, Dr. Lan Pham, is going to be giving a presentation today on palliative care as it relates to ALS. He is really the state's leading expert on palliative care in ALS and is overseeing the program that we have here at Our Lady of the Lake, which is a multidisciplinary program. And palliative care has really contributed so much to the care and I think well-being of these patients. And I'm very excited that Lon has agreed to do this presentation. Thanks, Lon. Take it away.
Thank you, Mark, for the introduction. I'm just going to start off with a quick video of this patient.
Hi, friends. I have some sad news to share. It's actually devastating to me. I've been diagnosed with vulvar onset ALS, the same disease through my mother's life 20 years ago. I inherited the genetic mutation from her, except she got it at 60. Meanwhile, I got it at 50.
Ugh.
I never expected my life to end so soon. I'm being cared for at the UCLA ALS clinic. In the coming days, you will see a GoFundMe for my benefit launch. Because I've been chasing a dream, I will only get $1,183 from Social Security disability. So I hope you will donate to me if you're able to. Thank you.
Good afternoon, everybody. Thank you for joining me on this talk about ALS and what we do in our ALS clinic. That was in 2 minutes or less. It's a great example of ALS presentation and initial diagnosis. As you can see, this young lady who's informing the world essentially online about her new diagnosis. And there's a lot to take in that short video. You can obviously, she's got dysarthria as an initial presentation already. The voice is already weak. You can see very clearly that she has to stop, focus, and concentrate on her swallowing. I would imagine that she's got significant sialorrhea in addition to her dysarthria and dysphagia. And so the presentation of her symptoms is pretty evident. And that kind of goes into what she described as bulbar ALS. So it's you have ALS, but you have different subtypes of ALS where we subgroup into bulbar versus limb. We're going to go into a little bit about the differences and how it affects patients first, but understand bulbar is the more aggressive type of ALS. She also talked about the mutation. I'm sorry, the genetic mutation. 10% is genetic, passed down from family to family. The other 90% are sporadic, environmental factors, toxins, trauma, all those oftentimes influence the expression of ALS. But 10% is genetic and passed down to other family members. She did also talk about being cared for by a multidisciplinary clinic, and we'll kind of touch on why that is important as opposed to fragmented care from different clinics. And lastly, ALS can be a very expensive illness, unfortunately. And she talked about getting a GoFundMe page, and we often do see that where financial freedom is going to be important in terms of the decisions that you make. And I'll kind of go into that a little bit as well. But I thought that was a great introduction video to it. So my name's Lan Pham, and I work at Our Lady of the Lake Palliative Care Team with Dr. Mark Cantrow. I have nothing to disclose. I'm not paid to do the talk, although Dr. Cantrow owes me a very expensive dinner after this because he asked
That's
me.
right. I'm going to you tell me where.
But I really enjoyed putting this these slides, this talk together, and help me kind of reflect on my my work with our ALS clinic. So I do work for the I think it's called Our Lady of the Lake or Lake Primary Group ALS Clinic. I'm one of the original founding members. And I also serve as the co-medical director for our clinic from a palliative and supportive care standpoint. So today's talk, I'm going to go through a couple of physical symptoms that we encounter a lot, and then we'll go through some psychological, spiritual, emotional issues. Talk a little bit about hospice enrollment, talk a little bit about medical aid in dying, and then top it off with current medications that we have available to treat ALS. I have another video that I'm going to show you. Most of my talks is going to be on video. I was hoping to do that without, oh, there goes it.
Amyotrophic lateral sclerosis.
But due to time, I'm going to go ahead and just kind of go over it pretty quickly. There's a few videos that I do want to show you that's more impactful, but just to speak very briefly about the pathology of ALS, it is a degeneration of the upper and motor neurons that leads to denervation of the muscles, leading to paralysis and generalized weakness, and eventually what is similar to what we call a locked-in syndrome. Oftentimes, it does not affect us cognitively, but there is associations with frontotemporal dementia with ALS. But mostly it is a motor disease, motor neuron disease, and affects muscles with weakness. There is no known cure. It is terminal. Unfortunately, there has been a lot of research as of late for treatment options, but still no cure. The life expectancy is about 3 to 5 years. Again, not a lot of time. You're gonna see some of the slides, some of the information that is red, and this picture is going to pop up. This is Danielle. When I did this talk, I also wanted to kind of make sure that we do have a fellowship program in our department that Danielle is able to get some information out of this for her own studies. So I recertified last year on our palliative and hospice boards, and I remember going through some of these questions that are in regards to ALS. So I want to make sure that she gets some of this benefit. And then we talked about the 10%, it being a genetic component being passed down to family members. So one of the videos I do want to show you is this Mr. Kevin Swan here. I'm going to actually mute this while I talk, and y'all can watch if you can see it. Him kind of struggle through his daily life. So he was diagnosed with ALS about 2012, and he is posting videos of his journey online. And again, it's a wonderful representation of kind of like daily life. But down at the bottom, I want you to focus on the progression and timeline. Early stages of ALS can be very simple. So there's a difference between bulbar and limb ALS, where bulbar, the initial presentation is speech difficulties. You feel like you're losing your voice, or your voice becomes very weak, some dysarthria. You have a disability of swallowing, and those would be more of bulbar type, upper respiratory type of illness. As opposed to limb presentation, you're looking at, all of a sudden you're tripping over yourself. You keep falling down and you have a foot drop, or you're holding a cup of coffee and you drop it because you can't keep it held. So those are more presentations for limb. It makes a difference in terms of that subtype of ALS, because unfortunately with bulbar, progression seems to be a lot faster, is what we understand. Patients reach end of life a little bit sooner as opposed to limb. And so there's quite a big difference when you're diagnosed with bulbar versus limb. In the middle stages, you continue to progress with muscle weakness. You may require rolling walkers, power chairs to prevent falls, again, worsening with swallowing and breathing at some point. And then towards the end stage, you're looking at pretty much severe paralysis. And again, kind of like in that locked-in syndrome, where one patient describes it, where you are dependent on a machine to breathe. You have a PEG tube to get nutritional support. You're confined to a bed and chair, pretty much limited in everything that you had been doing before. So that's the later stages of ALS. The importance of that is that everybody progresses so differently. The slide on your left, the graph on your left, kind of compares ALS versus PLS, which is primary lateral sclerosis. It's sort of like a cousin to ALS. Patients, however, have a longer survival, and it is a much slower progression. You're looking at decades, where ALS is 3 to 5 years. But the important point of this slide is that there's so much variation in how patients progress. You're looking at certain patients who progress very rapidly, certain patients who progress very slowly. And that becomes very important because in our clinic, we try to identify how these patients will behave in the near future so we can help. And so we have a multidisciplinary team where you have neurology, pulmonology, speech, you have palliative care, supportive care team, respiratory. You have everybody on the same roof. And the goal of our clinic essentially is to kind of follow these patients. And every time they come in 3 months, we assess their motor skills, assess their swallowing, and try to prevent crises from happening as much as possible. So if we understand that this patient is going to progress within 3 months, for example, with dysphagia, we don't really want to wait until they aspirate, develop a pneumonia, end up in the ICU on a ventilator. We want to be proactive and say, hey, I think it's very close to the time we need a feeding tube placed, so you don't aspirate. And so that's the power of the multidisciplinary clinic in order to be able to do that. And by just documenting how the patient progressed, the rate of decline, we're able to kind of map out, okay, this is what we expect within 3 months, within 6 months. Very important to do.
Oh.
The next slide, don't tell me ALS does not hurt. So we'll start going to the physical symptoms and presentations of our ALS patients, and they hate it when you say ALS does not hurt, especially from neurology. The neurologist explains, well, this is a motor nerve issue. It makes your muscles weak, but you shouldn't have pain. They hate hearing that because it does cause physical pain. They have muscle spasms that can cause a lot of discomfort, cramps. They're very stiff. So, pain from osteoarthritis, pain from contractures, So yes, I would agree with the patients that it is significantly an issue where pain control is needed. And oftentimes in our clinic, we use a lot of anti-inflammatory medications initially. We use a lot of muscle relaxants for muscles and crampings. We end up doing some opioids as well. And since the use of therapeutic marijuana has been legal in Louisiana, we have actually been doing a lot of that as well to help our patients. And we'll go into therapeutic marijuana in a second as well. The first symptoms I want to discuss is sialorrhea. Just a lot of difficulty swallowing, not necessarily overproduction of saliva, but just inability to swallow. And this could be very embarrassing to the patient. This can cause a lot of discomfort, leading to a lot of social isolation. But worse, now newer studies find that with uncontrolled sialorrhea, you have a lot of patients who are becoming very intolerant of adaptive breathing devices, including BiPAP, because of sialorrhea. And without the non-invasive ventilation, the BiPAP, their life is shortened. So this becomes a very significant symptom to treat early on, so that it does affect, again, prolongation of someone's life. And oftentimes we have a few medications at our disposal: atropine drops, a lot of anticholinergic medications. Glycopyrrolate is one of the newer ones. We put scopolamine patches on, but the sexy thing I would say is we do Botox injections, and sometimes do localized radiation to the parotid and submandibular glands. We have not done that. We haven't gone that far, but we do a lot of Botox injections. In the middle of the slide, I put down glycopyrrolate versus scopolamine, because these molecules, again, when they're certain difference in molecular biology or chemistry, it affects how it is absorbed. And so one of the things, again, going across our boards from last year is glycopyrrolate is more hydrophilic, and so it does not cross the blood-brain barrier. This becomes very important, as opposed to atropine, scopolamine. Glycopyrrolate causes less restlessness and confusion and hallucinations, especially for those who are end of life and already have hallucinations, confusion. You don't want to make it worse. The answer to that question is to use glycopyrrolate. This is the Botox injections that I was referring to. Our neurologist does them in our clinic, and you identify the location of the parotid gland or the submandibular gland, and you put Botox injections there to decrease the saliva production. We did have a patient that complained of xerostomia, just dry mouth, and just made it even more difficult for her to swallow because her mouth was so dry. So you kind of don't want to inject all the glands, maybe two or so, and just limit the saliva production as much as we can without going into causing xerostomia. Another serious symptom is muscle spasms, cramps. And this is a video. You can obviously see, if it's loading, patients go through these muscle twitches and cramps. And this could be also debilitating. I've had a patient a few years ago who had significant, I'm sorry, it's not loading, significant, there it is, symptoms where it was really discomfort, very uncomfortable and painful. And we had to resort to higher doses of opioids and changing and switching to methadone. And it gotten to a point where I made home calls every week to adjust his methadone because he was so uncomfortable. I'm certain there might be another underlying issue, or that's something we have not diagnosed. But it was a continued escalation of methadone. So on your left, these are different medications that we use. We start off with, baclofen and robaxin and Flexeril, the usual medications for muscle spasms. Sometimes benzodiazepines and gabapentin. Sometimes if it's local, we can do botulinum toxin injections for muscle spasms as well. The other thing is medical marijuana. Again, there's been a lot of excitement around cannabinoids and its effect. I don't know if y'all remember when medical marijuana was approved in the state of Louisiana, it was for certain medical conditions, right? Spasticity, muscle spasticity was one of the medical conditions. And then we said, definitely this is a medication for RLS patients. So we started using that in our clinic. The mantra of medical marijuana is it has multiple uses: pain control with anti-inflammatory effects. It is antioxidants, and then it's also a neuroprotective antioxidant as well. And that becomes very important, and I'll tell you why in a little bit. But, it helps with drooling, dyspnea, appetite stimulation, these things that we know about medical marijuana uses. So we've been pretty fortunate that we have been able to use medical marijuana in our clinic, and our pharmacy, the medical marijuana pharmacy is just right down the street from us. So it's very easily accessible. We're going to move on to respiratory symptoms, which is very significant. Unfortunately, the majority of patients with ALS die from respiratory failure or its complications. And you can have either hypoxemia and hypercapnia, nocturnal hypoventilation, siluria, we just talked about, mucus plug occur a lot, and patients end up in the hospital. Aspiration pneumonias occur very often. We had one patient in the hospital a couple of weeks ago with just spontaneous pneumothoraces, just significant large pneumothoraces requiring chest tubes. So there's a lot of respiratory failure issues that occur. Recently, hypercapnia and nocturnal hypoventilation has been in a lot of studies, because we want to focus on this, because this could be early indicators for non-invasive ventilation. And we'll also talk about that in the next few slides. The pathology for respiratory failure is the phrenic nerve is denervated, and it affects the diaphragm. But with ALS, again, it not only affects the diaphragm muscle, but also the accessory and bulbar breathing muscles as well. In this picture, you can actually see elevated right side of the diaphragm, probably from paralysis. And again, majority of ALS death is due to respiratory failure and its complications. Another thing I wanted to share with Danielle is one of the first things that we learned with ALS is oxygenation support. The problem with ALS is there's not a parenchymal injury or abnormality, it's the muscles. And so the best way to help support the patient is through doing a BiPAP or an adaptive breathing device to help the muscles breathe. What oftentimes happens is patients get into respiratory distress. They come to the emergency room, and the ER doctors, the medicine doctors slap oxygen on. Well, with no interparenchymal disease, it's not an oxygenation problem, it's a muscle problem. And so what ended up happening is that you're doing a lot of pure oxygen in, and you guys understand with oxygen, it decreases the CO2 drive, causing the respiratory drive, causing CO2 narcosis, makes the hypercapnia even worse and patients more confused. And so the answer to the question on the board is you don't slap O2 nasal cannula, you put them on BiPAP or you put them on a Trilogy device. And then with respiratory, there are certain things that you can look at to kind of help us understand are the patients how severe the patient's illness is, looking at the serum chloride. If it's low, it kind of reflects respiratory acidosis from respiratory failure. And then you'll hear a lot, I'm going to talk about forced vital capacity that we use in our studies to determine the severity of illness with ALS respiratory. So let's look at the data out there for respiratory failure. You want to ask the question, we have these adaptive breathing devices like the BiPAP. Nowadays, we use Trilogy, which is a combination of non-invasive ventilation, which is BiPAP, and then it can also transition to invasive ventilation, which is the ventilator. So it's pretty useful. It's small. It's very handy. It's portable. It's a great tool for our patients. So the question being is, does non-invasive ventilation help? Does it prolong survival? Does it affect quality of life? When should we start using non-invasive ventilation devices? So I'm hoping to answer those questions through the data that I want to present. So this is a study, unfortunately, a small study that came out of Hahnemann University in 1999, looking at 3 groups. The first group, which is the darker color, is group 1, who uses the non-invasive ventilation device more than 4 hours a night. Group 2 is patients who use non-invasive ventilation less than 4 hours at night. And group 3 is patients who do not want to use non-invasive ventilation or is intolerant. So that will be our control. So as you can see, there is significant statistical significance in terms of survival, looking at the months here on the side, 14 to 16 months in group 1 compared to group 2, and then group 2 compared to group 3. So there is a increase in survival benefit. And the theory is that it does a lot more, but it reduces the work of breathing, it improves gas exchange, it also improves sleep quality and compliance. So now we kind of starting to look at sleep quality, which is going to be very important in the next later slides too, because it does affect quality of life. So the same study also extended to patients between 12 months and then 18 months. And then you can see the survival rate again is greater in group 1 at 12 months. But by the time you reach 18 months, the benefits kind of weakens a little bit to 21% in patients who use non-invasive ventilation over 4 hours. And so according to the study, when you start non-invasive ventilation, it does improve survival, prolongs your life. 12 to 18 months is what most of the studies later on also confirms. The interesting thing in this study also is how earlier I talked about the differences between bulbar symptoms and limb ALS, bulbar ALS and limb ALS. And we know that bulbar ALS has a shorter lifespan. They progress faster. Their respiratory failure progress faster as opposed to limb ALS. However, in this study, it found that when you put these patients on BiPAP, the reverse is true. And so when you provide them support with breathing, bulbar patients end up living a little bit longer than limb ALS. So that's quite interesting. Other studies are not so confirmatory, but I thought in this study it was pretty interesting that bulbar survival kind of flips when you start patients on BiPAP. So non-invasive ventilation does help prolong survival, but does it slow the decline of the forced vital capacity? Again, this is the standard that we look at right now, looking at the how severe the illness is. A lot of the previous studies look at forced vital capacity percentage. And so we do know that, again, with bulbar and lumbar limb ALS, the average of decline is pretty linear. It's pretty linear. I think maybe FVC declined 3.5% every month. And so in this graph, the vertical line is where you start BiPAP. And then you can see the trajectory of the FVC. It actually slows down. Group 1 flattens out. Group 3, which is, again, groups that don't use non-invasive ventilation, worsens. And so it does slow down the rate of respiratory decline when you use non-invasive ventilation. And this study, again, in 1999, showed that FVC percentage recommended to initiate non-invasive ventilation around 50%. And this is when patients really have significant issues with breathing. And the other question is, does the pattern of use of non-invasive ventilation, does that have an effect? Again, the previous studies is 4 hours, less than 4 hours. Well, in this one, this Canadian journal, patients who have used non-invasive ventilation less than 4 hours, 4 to 8 hours versus greater than 8 hours. And this is just the raw data. Patients, you have a little bit more patients surviving up to 10, 11 months when they use the non-invasive ventilator longer than 8 hours a day. So pattern of use also very important. So the next question then becomes, well, if 50% is the cutoff, so what happens if we try to ventilate these patients earlier? Is there any benefit? So in this study, you're looking at the FVC, the forced vital capacity, 75%. And so according to this graph, the circle represents patients whose FVC is greater than 75%. The diamond represents patients who started non-invasive ventilation at less than 75%. And the square is non-use of a ventilator. And so there is no statistical significance between greater 75 and less than 75%, but there is a significant statistical significance between less than 75 versus no. So now, should the recommendation become initiating non-invasive ventilation if a patient is less than 75%? We don't know, because now there are other studies that are coming out that is saying, well, non-invasive ventilation, if it does provide some benefit at 75%, should we go above 80%? The importance of this study is that it recognized hypercapnia, and it recognized nocturnal hypoventilation as one of the symptoms. That is when we should initiate non-invasive ventilation. This is very important because, again, sleep quality is very important. Sleep quality without nocturnal hypoventilation, without apnea, affects your somnolence, daytime somnolence. It affects your fatigue. It affects cognitive impairment, and it's been shown to affect depression as well. And so the question being, so if we start the non-invasive ventilation a little bit earlier, as soon as we identify hypercapnia or identify nocturnal hypoventilation, we should recommend non-invasive ventilation. The problem with this is, even if we go above 80%, the problem with this is that a FVC around 75, 80%, patients are not very symptomatic as opposed to 50%, right? And so what's going to be the compliance rate? If we recommend the non-invasive ventilation and they don't feel bad, are they going to use it? Probably not. And the other barrier to this is that the insurance company, right? They, we have these studies that shows evidence, but insurance says, well, if we can't pay for this unless they're a certain level, I'll leave it at that. But again, the rate of FVC decline is affected by at 75% versus none. So you can see the flattening out with the blue line as opposed to the red line, which is your control. So we have evidence that non-invasive ventilation does affect survival, a prolonged survival, 12 months, 18 months. Does it affect quality of life? In this study, and I apologize for not doing the biology, bibliography. I'll get that to y'all later. But this study looks at sleep scales, Pittsburgh Sleep Quality, quality of life questionnaire, and even the functional rating scale scores. And it actually shows a benefit. And so remember I said sleep quality is very important for quality of life because it affects your cognitive impairment, it affects depression, it affects daytime fatigue. And when you place somebody on a non-invasive ventilator, it improves that. It improves your sleep quality and thus prevents cognitive impairment, depression. And so that would be a quality of life game changer. So overall, you're looking at non-invasive ventilation, a positive effect on prolonging life and quality of life. Dysphagia. We ask the same questions about dysphagia. When do we put a PEG tube in? Is it helpful? Does it prolong life? I know that traditionally you're looking at when you're talking about dementia patients, we always are taught that PEG tubes it doesn't prolong life, it doesn't improve quality of life, and we don't recommend PEG tube in advanced or end stage dementia, right? However, again, on the board questions for Danielle, you're looking at there are certain conditions that a PEG tube may be helpful, and that one of that is ALS. Others would be strokes, patients, or head and neck cancer, again shown to prolong your life. So in this study, you're looking at all comers, all PEG, part A, you're looking at PEG patients who are PEGulated, and those who are not on pegged, survival is a little bit longer. When you compare to LIM and bulbar, again, we already know and understand that LIM has a better survival rate than bulbar, but what happens with a PEG tube is placed? Well, the LIM, again, ALS patients survive longer than bulbar patients. And you compare from limb to limb, with and without PEG, obviously, all across the board, essentially, bulbar versus bulbar, all across the board, PEG tubes increase survival. The question becomes, when do we put it in? You're looking at, again, the FVC, placements, patients receiving PEG tubes when the FVC is less than 50%, 50 to 60% versus greater than 60%. And what this shows is that when you place a PEG tube between 50 and 60%, it has a better survival rate than less than 50. But the most benefit is placing a PEG tube when somebody's above 60%. And this is more so because of the respiratory failure. Remember, when you're at 50% FVC, you're very symptomatic. And so, you could get more respiratory complications with any procedures. The thing that we advise our patients is that surgery and ALS do not go together. You can do the surgery, but your recovery is going to be much, much more challenging. And so in this study, again, the recommendation is probably best to place a PEG tube when they're above 60%. However, newer studies are coming out that, the technology is much better. Traditionally, we would ask our gastroenterologists to place PEG tubes, but now we have interventional radiologists. We have radiologists to put in PEG tube, which is a little bit easier. And they could actually use their non-invasive ventilator while they're putting a PEG tube. And so the recommendations now is that, yeah, you should put a PEG tube greater than 50, 60%, but it's not contraindicated if it's less than 50%. You can put it in, but probably recommend a radiology to put it in rather than a gastroenterologist. So does the PEG tube have any further effects? We now know that it does prolong survival. Does it slow down the functional ALS? And the ALS functional rating scale revised is a scale that we use in the clinic, and we use it a lot in our studies as well. And it's a scale, I think, developed by Dr. Appel in the Houston clinic. That may be true. Somebody let me know if I'm wrong. But it's like a 12 to 13 point scale where it assesses mobility, it assesses communication, dysphagia, respiratory. So 13 assessments, and they scale it 0 to 4, 4 being the normal and 0 being very deficient. And so by doing that, you can kind of total up the points, and at each visit every 3 months, you can tell, okay, are the points going down, or are they stable? If they're going down, how fast are they going down? And so that's how we tell what the progression of the patient is. But unfortunately, PEG tube does not slow down the functional ALS according to this graph. It does stabilize, however, weight and BMI. It doesn't necessarily make you gain weight, but it stabilizes weight and BMI, which is important because when you're looking at ALS, one of the reasons why we do a PEG tube is not just for dysphagia and preventive aspiration, but we also look at the weight loss or the rapid amount of weight loss in BMI, because again, that is affecting prognosis. So the faster you lose your weight, the faster you lose your BMI, you progress faster in terms of the ALS. So it's very important to stabilize that weight loss and stabilize that BMI. So this exactly what I just said in this slide. It stabilizes the weight, and then it stabilizes your BMI. This is PEG tube compared to no PEG tube at 6 months and 12 months. Obviously, you can see a difference. And then on the right, PEG tube versus no PEG tube, BMI kind of improves and stabilizing with PEG. So now the question becomes, do we do it earlier like we did with non-invasive ventilation? We went from 50% to 75%, and maybe the recommendation now is greater than 80%. However, that is not true for PEG tube. And so this study showed, looking at survival rate for patients who placed a PEG tube before 10 months versus 10 months, right? So the graph on the left is a comparison between PEG tube versus no PEG tube. Obviously, PEG tube survival is longer. And then on the left, you're looking at the dotted lines is PEG tube placed less than 10 months versus PEG tube placed greater than 10 months, survival is actually better with greater than 10 months. So there's no benefit of doing an early PEG tube placement. This graph shows hospitalizations, actually complications with patients who placed a PEG tube greater than 10 months is actually more than patients who had an early PEG tube placement. So sitting down and talking with our respiratory therapists, my two pulmonologists and speech therapists, and looking at these data, what is our recommendation? And this is where the science becomes an art, right? You have different recommendations, but what they tell me is that it kind of really they take into account a lot of variables. Looking at the FVC, looking at whether a patient has sleep apnea or hypercapnia or a nocturnal hypoventilation, or how the patient feels. So they take all that into consideration. So we don't usually wait till FVC less than 50% and say, okay, it's time for non-invasive ventilation. But we do all that, and we do all that with our discussion about whether or not this is right for them. Do they want this? And what their thoughts on that is. And so that's when we come to a decision together, physicians, therapists, and the patient and the family, to say, no, we do not want non-invasive ventilation or invasive ventilation. And when I say non-invasive ventilation, again, this is the BiPAP machines, this is the Trilogy machines, this is not tracheostomy and or chronic ventilators. So that is invasive ventilation. So that's a separate conversation that we have with the patients about whether or not these advanced technologies is right for them, right? Many feel that when they're on a chronic ventilator with a tracheostomy, they feel like there's no quality of life. And that really is the deciding factor for many patients. So I think nationally, less than 10% of ALS patients decide to move on to tracheostomy and mechanical ventilation. PEG tube, however, is more widely accepted. So I have 10 minutes left. I have a lot to go. This is Joaquin Phoenix. I don't know if y'all seen this movie, The Joker. This is, he portrays a psychotic person with pseudobulbar affect, right? The uncontrollable laughter, uncontrollable crying. And so this is the next symptom that I want to address. Now, ironically, I'm putting this picture here, and again, he's a psychotic character that he plays in the movie, but I want y'all to know, and I'm stressing this point, pseudobulbar affect symptoms are not psychiatric, it's neurological. Whoop, let me go back.
Yeah, I'm looking happy. I'm not sad. It's in my grandma's room. My best friend. And then I'm trying to cry, but I'm bust out laughing. They're like, damn, Kirk is really crazy. Not crazy. Not crazy. It's not my fault.
All right, I'm going to stop the video from there since time. But it is, again, a neurological condition. It's uncontrollable, inappropriate laughter or crying. It's involuntary, you can't control it. And again, it offers a lot of embarrassment, anxiety, leading to social isolation in a lot of our patients. So the pathology is a hypothesis, unfortunately. You're looking at different pathways from the cortex to the cerebellum, and there is a disruption or a sever of these pathways that leading to uncontrollable emotions, including laughter or crying. There are medications that are helpful. One, Nuedexta. It is a combination of quinidine and dextromethorphan. Nuedexta can be expensive, so sometimes we just prescribe quinidine and cough medicine. But is it effective? It is effective, looking at 30 days and 90-day results in this graph, where there's decreased incidences per 30 days. And in this graph, it's pseudobulbar affect is not just a symptom that is inflicted on ALS patients, but basically any neurological disorder. This includes trauma, head trauma patients, multiple sclerosis, dementia, stroke patients. And so Nuedexta actually all across the board is able to help reduce these symptoms in these multiple illnesses. So this is one of my favorite slides that I made. We'll kind of focus our attention to more of psychological and emotional issues. I really like this slide because it's serene to me. And then if you kind of look at it closely with the title, I Lost Myself, you see these waves coming. And it's kind of like an analogy to life or ALS. These waves keep coming. They keep coming whether you're ready or not. And when these waves come, sometimes it consumes you, it overpowers you, or it doesn't. And then when the waves leave, you're left standing. You're still there. So I kind of thought about that when I was putting this together. But we do have a lot of patients who go through a lot of emotional issues. Initially, denial. It takes a long time to diagnose these symptoms, the ALS, and many come to our clinic thinking that they don't have it, or they pray, they bargain that this is not it because they know what it means. We are very fortunate. Again, any ALS clinic should have a psychologist or a counselor, palliative care, to kind of address these emotional, psychological issues as opposed to just symptom issues. And I urge any ALS clinics out there, again, to have some type of support, because when you're talking about end-of-life care, this is one of the major influences of the decisions that you make. How well you're doing, what your quality of life is, and how you're doing in terms of your depression, anxiety, or psychological issues. Loss of identity, very important. We have a lot of patients who are very successful. We have doctors, we have CEOs and lobbyists, and many people see this as a loss of who they are. And where before they're in charge of people, they're in charge of companies, and now they're just dependent on everyone. Just listening, empathizing, and counseling them to change and adapt to the changes that they're going through. Hopefully, they can find it with themselves to find new meanings and find new passions and new purposes in their life to help them through that. There's loss of independence as well. We have a gentleman who his daughter was having a wedding in 3-4 months, and he, as a duty, as a father's duty, he wanted to walk her down the aisle. He wanted to dance the father of the bride dance, be able to do that and function as his role as her father. And so, credit to our physical therapy team. They are wonderful. They made house calls. They worked with him. They got him ready to go to this wedding. We even offered to be there, his own personal medical entourage at the wedding. But fortunately, he was able to do it. He was able to walk her down the aisle. Credit to the special people in our clinic. Loss of control. I'm going to move through quickly due to the time. Loss of control, very important. Loss of dignity, also very important. This is Steve Gleason. This picture was taken when they unveiled the Rebirth statue at the Superdome. Those who know Steve Gleason, founder of the Gleason Foundation, he had this documentary called Gleason out, and I saw that. And right after they took his picture, he admitted in his documentary he is being honored for this, this great accomplishment, this honor. And then when he went home, he had people changing his poop diapers. So there's a lot of significant loss of dignity with this illness. You're talking about the sialorrhea and the subbulbar affect. Again, social isolation. You can't really, you should be able to continue living your life and doing the things that you do. To help these patients, again, counselor, supportive care, kind of getting them through these stages of denial, anger, and bargaining, finally to acceptance. And you just listen and you try to get them to acceptance as much as you can. I really like this slide because of the difference between positive coping mechanisms and negative coping mechanisms. We try to change the negative coping mechanisms to try more of a positive, active coping mechanism that allows them to again, go through the stages and accept. And this is kind of like the graph where on the left, you're hurting, and then you go through all these different stages and you go back up and you found adjustments and you found acceptance and you found hope and affirmation. Sometimes we hope that this is how the curve works, but in my experience, this is usually what happens. It's all over the place, especially in our clinic. And we do have patients that make it. We do have great patients that, accepts what they have, live their life with quality. We have patients who found new purpose, new identities. And this gentleman, one of my favorite patients, a sense of humor as well. Medical aid in dying. So I had this one patient a year and a half ago who came to our clinic, first visit, and then after the visit, she called and said, "Hey, I want to talk about medical aid in dying." And I said, "Okay, we need to really sit down and talk about this." So I got her to our clinic, and she brought her 2 sons. And I think the first thing is to determine the nature of the request. Is this something that she's just entertaining? Is this something that she just wants to know about? But this patient actually was determined to pursue medical aid in dying despite the barriers, because the barrier in Louisiana or Mississippi is that we do not have medical aid in dying. But the sons were ready to move her to a state that was. So I realized that it was a very serious request. And so on the board questions for Danielle, that's the first thing that you do. When somebody asks you about medical aid in dying, you inquire, okay, is this a serious thing? Is it just a passerby thing? What is the nature of your asking? So you understand the concerns, you respond empathetically and respectfully, you address depression and anxiety. If you need an expert, send them to a psychologist. If you're inexperienced, you can send to another colleague that has an experience. But what you don't do is abandon. You continue to work with the patient. If you feel uncomfortable as a physician to do medical aid in dying, you send them to somebody who is comfortable. Also on the board questions, each state has different rules in this, and so they're not expecting you to know the rules. It would not be fair. So you wouldn't have to kind of go through that. So what happened with the patient was that we sat down and we talked about what she's going through, what she's feeling, and her concern was she didn't want to lose control. She was concerned about future pain, future starvation. She didn't want to go through any suffering like that. She didn't want to burden her 2 sons with that. So then we ended up talking about other ways that that she could do without having to resort to medical aid in dying. So this is talking about discontinuation or life-prolonging treatments, including not accepting PEG tubes, but do pleasure feeding, not doing ventilation, tracheostomy. And once we're able to talk about that and really identify what she's suffering from and be able to counsel her on that, she was good. She no longer requested medical aid in dying. Eventually, she passed away with hospice benefits. And again, if you're important test question, also if you're uncomfortable with the request, you shouldn't just say, hey, you know, we don't do this in Louisiana. Let's sit down and talk about it. You don't abandon them. If you're uncomfortable in states that do, and if you're still uncomfortable, then you try to get them to somebody else who would be comfortable in doing this, and hopefully to allow continued relationships. Lots of states, 10 states, including Washington, D.C., District of Columbia, that do have laws for medical aid in dying or death with dignity. You look at Montana. Montana is a little bit different because it has to go through the courts in order to get death with dignity. The courts decide that, and not the patient-physician relationship, which is interesting. So as I said, that, you know, the patient would have to establish residency. Oregon recently, June 2023, there was a lawsuit that did away with that rule where you do not have to be a resident of Oregon to pursue death with dignity. Just a modest increase in medical aid in dying. And so what are the people? Who are the people who are asking this? These are male. In this study, male equals female, mostly Caucasian, mostly single, and independent living, and a lot of cancer population. And notice at the bottom, it's mostly non-hospice patients who are requesting. And so for about 27% of hospice patients, that's pretty good because they're probably receiving good palliative care. And there was no need for medical aid in dying. A lot of Christians in terms of religion, median age 46 to 75, higher education, middle-class folks. So we're not talking about, you know, uneducated, but very educated people who are inquiring about medical aid in dying. Again, a lot of cancer patients, not confused, life expectancy greater than a month. Less than a month, I'm sure they maybe can unquote, quote, stick it out. And usually they have a conversation with patients, the physician who they have a relationship with greater than a year, where they feel comfortable in talking about that. And so what are the reasons for asking? Again, wanting to control or losing control of their life. They feel very uncomfortable. Future pain, future quality of life, not current pain or quality of life, but future, worry about the future is another main reason. Loss of independence and inability to care for oneself. Again, these are probably the more frequent reasons why they would ask for medical aid in dying. Goals of care.
Doc, we have 3 minutes.
Okay.
Thank
So let's skip over this. I just want to go through this justice. I do struggle with this about the principle of justice, about equal distribution of resources. There's a lot of injustice, I would say. I think me personally, this is an illness that is imbalance between the haves and have-nots. If you have the financial freedom to do home care, sitters, this will be very, it's a little bit better quality of life. We do have associations like the VA, who's been very helpful. The Gleason Foundation, ALS Association, all has been very helpful. And then even discussions about ventilators and invasive ventilation is imbalanced because if they don't have the support, the people to take care of them after they do a trach, we can't offer them a trach if they don't have the team to take care of them. You know, in the hospital, when we do trachs, we send them to nursing home, but these patients go home and they're cared for by their family. So significantly, a lot of justice issues and imbalance. Ice Bucket Challenge 2014, major thing is the awareness that caused this, that spurred a lot of donation money, and this is from the ALS Association, how they distributed that money. But the biggest thing was it went viral. A lot of social media and a lot of ALS awareness, which is, again, like I said, is the most important thing. And that led to medications like Relivrio. That money actually pushed this medication out. It does help with prolonged survival. It does help with decrease in decline as well. And the other two medications were Riluzole and Radicava. So we have three. Sometimes we have patients on all three because they have different modes of mechanisms. Metformin is another interesting thing. It's in studies right now in patients who have this type of gene. In mouse studies, metformin seems to improve survival. Okay. I'll be waiting for that study to come out, but because metformin is cheap and it's used all the time. More weed. This is what one of our patients said when we asked if there's anything more that we can do. He asked for more weed, so I looked into it. And medical marijuana actually could, again, also a study to help slow down the progression by decreasing glutamate and decreasing exocytotoxicity, which is a neuronal damage. It binds to the C1 receptor, C2 receptors, and cause that. So studies in mice right now, that may be coming out at some point. Diaphragm pacing is a no-no, doesn't work, actually harm. The theory is that if the phrenic nerve is denervated, try to excite it. So this is Mr. Swan, 6 years later, the gentleman that who we talked to. Notice that he's no longer speaking. He's got a computer narrating this. Now he's on invasive ventilation. And
it might be hard to believe, but in my head, my daily life seems just like every other Tom, Dick, and Harry. I don't open my eyes in the morning and say, "Damn you, ALS." That would be a waste of time and energy. I get up every day with the intention to be as productive as possible. Well, at least after I have some coffee, I feel that way. It's been over 6 years since my body started to crumble from the outside in, but my mindset has always remained the same. I will not let this disease define me. So, I have machines to help me breathe and cough. And I eat through a tube and type with my eyes. Good morning. Faith and an open heart, I promise you two are going to hit rough waters at some point. It's inevitable.
Doc, I want to thank you for your presentation today.
Look around and hope
We have another meeting that is waiting for this line to take place.
Sure.
So
okay, I appreciate it. Sorry, we're over.
We appreciate it. We will make this available online to those palliative care members who couldn't show up today at this time.
Okay.
Thank you.